Opinions and approaches of pediatric surgery specialists and residents about neonatal resuscitation program NRP. Survey study. YESİM Şenaylı, Rezzan Kaplan Sayar, Sevgi Ulusoy Tangül. Introduction Neonatal Resuscitation Program, NRP, is a course first launched in 1985 by the American Heart Association, AHA, and the American Academy of Pediatrics, AAP. The program was initiated after studies found that most children requiring neonatal resuscitation did not receive appropriate assistance. The primary purpose of this training is to prevent deaths and disabilities, mainly due to asphyxia, by training healthcare professionals who can evaluate the newborn at the time of birth and perform resuscitation on babies who have difficulty in transitioning from the womb to extrauterine life. 310-19% of births in the world require resuscitation procedures at birth. There may be a need for positive pressure ventilation, PPV, in 3% and intubation and cardiopulmonary resuscitation in 1%. However, on average, 4 million newborns are affected worldwide yearly. In fact, in some countries, perinatal asphyxia is the leading cause of neonatal death. One study determined that, when evaluated in general, 98% of deaths occur in countries with low or medium development levels. In a study conducted in China, it was determined that the cause of 20.5% of newborn deaths, that is, the deaths of 73,000 babies, was perinatal asphyxia. This number was determined to be 29,000 annually in Ghana. When we look at the ratio of the populations of China and Ghana, it can be understood that Ghana's losses are high. If newborn deaths in China were based on the rate of Ghana's population, it would mean 1,400,000 newborn deaths per year. However, perinatal asphyxia also has the effect of causing cerebral palsy, epilepsy, and chronic neurological diseases in a significant number of newborns. The neonatal resuscitation program includes general practitioners, pediatricians, emergency medicine, family physicians, anesthesiology and reanimation, gynecology and obstetrics, pediatric surgery doctors, as well as midwives, nurses, anesthesia technicians, and medical officers, whom we can call those who touch the baby at the time of birth. It is aimed at allied healthcare professionals, such as emergency medical technicians and paramedics. The knowledge and skills obtained through this training program are used not only in the resuscitation of babies at the time of birth, but also in neonatal resuscitation, which includes the first 30 days of life, regardless of the branch. The most critical factor that affects the quality of education of healthcare providers who will take the NRP course is that they have knowledge and skill training that can be compatible with the NRP course in their training curriculum. In a study, the conditions of pediatricians, anesthesiologists, and gynecologists during the course were compared, and it was understood that although pediatricians and anesthetists showed similar characteristics, gynecologists differed. There may be differences in the procedure levels of physicians working in pediatric surgery, but pediatric surgeons have almost no NRP training, skills, or knowledge of the literature. Therefore, in our study, we aim to analyze, through a survey, the approaches and opinions of pediatric surgeons who have to perform neonatal resuscitation in their professional lives regarding NRP training and practices. Methods 2 studies can be done regarding NRP activity. The first is to measure the successful effects of neonatal resuscitation practices after training. The second is to evaluate the course participants in terms of their knowledge level and skill confidence after the course. In our study, evaluation was made using the second method. After receiving the approval of the Yazgit-Bozok University Social and Human Sciences Ethics Committee, our research was conducted between October 2023 and March 2024 by asking participants survey form questions via communication tools such as email, telephone, social media, and the internet. The research population comprises pediatric surgeons and pediatric surgery assistants receiving pediatric surgery specialty training in Yazgit-Bozok University. All pediatric surgery doctors in the country will be included in the study through associations, academic platforms, congresses, seminars, etc., and social media, and the analysis of the data obtained from the study will be based on these data. Data were sent to participants in the form of electronically prepared survey forms via email addresses and social media platforms. All procedures were carried out in accordance with the ethical rules and the principles of the Declaration of Helsinki. Results according to the survey results. The numerical distribution of the opinions of pediatric surgeons at various levels who have taken the NRP course and those who have not taken the NRP course, and their knowledge, skills, and self-confidence are shown in table. The average age of 77 pediatric surgeons who participated in the survey was determined to be 43.8 years old. 37 participants were male, and 40 participants were female. 17 participants are residents in their first 5 years of education. 15 participants were 6 to 10 years in profession. 8 participants were 11 to 15 years in profession. 12 participants had been in pediatric surgery for 16 to 20 years, and 30 participants have been in pediatric surgery for 21 years or more. 5 participants answered the survey in Ministry of Health hospitals, 27 in state universities, 23 in Ministry of Health training hospitals, 9 in affiliated university hospitals, 4 in private hospitals, 7 in new model city hospitals, and 2 in foundation universities. 17 participants are residents, 24 are specialist physicians, 10 are doctor-lecturer, 12 are associate professors, 14 were professors. 48 participants took the NRP course. 29 participants still need to take a course. It has been determined that there are births and neonatal units in hospitals where the majority of course participants are. However, it has been understood that the cases in which physicians perform neonatal resuscitations are rare. It has been observed that the number of people who give positive answers increases as academic seniority increases regarding knowledge and skills and self-confidence regarding NRP. 16 of those took the NRP course within 5 years. 20 of them were 6 to 10 years ago. 7 of them were 11 to 15 years ago. 3 of them were found to have taken the NRP course 16-20 years ago, and 3 more than 21 years ago. It turned out that there were no repeat courses. The group that gave the least positive answers in terms of practice is seen as residents. This may be because they are at the beginning of their education process. However, the lack of births and neonatal units in the institutions where they receive training may be practical, based on the response given by this group. Discussion evaluation of the condition of newborns after birth started with the assessment scoring of Virginia Apgar, identified with her surname. Nowadays, it has become mandatory to evaluate babies, whether mature or premature, at the time of birth and to understand that their vital functions are expected in order to minimize the morbidity and mortality of babies. The level of knowledge about NRP at the physician level and ensuring that one person, whether a physician or not, is present in the team as an NRP-trained person during birth is essential in terms of reducing morbidity and mortality. Studies have been carried out on the knowledge and skills of this group, mainly due to the expectation that relevant physicians have mastery of the subject. In our study, it is pleasing that branches such as pediatric surgery, where the possibility of intrapartum work is relatively low, show interest in NRP programs and constitute the majority of survey participants. In the study conducted in China, it was determined that with the introduction of NRP applications, the time to start initial stage applications for asphyctic newborns was shortened. This valuable time was used well for diagnosis, and in this case, it made a significant contribution to preventing asphyxia problems in newborns. In our study, the number of people who answered, "I can perform initial practices when needed for resuscitation after the evaluation of the newborn," constituted more than 50% of the survey participants. 75% of those who could apply the initial step consisted of the group that had received NRP. It was evaluated as significant in terms of the effect of NRP. When respiratory weakness is detected in premature babies, the decision to apply positive pressure ventilation, PPV, may be indicated. In our study, it was stated that PPV could be performed at a rate of 63%. A study conducted in India found that only 18% of patients applied CPAP in the delivery room. It has been stated that in Kenya and Pakistan, training has been organized, especially on the use of balloons and masks, and that this is due to the conditions of the countries. It was determined that skill levels in this training remained at low levels of 31% in Kenya and 46% in Pakistan. It has also been stated that this may be not being accustomed to the OSCE training method. There is no need for such separation in our country because standard facilities are provided for NRP applications in the country, and deficiencies are quickly reinforced. A benefit of NRP courses is the awareness of the intertwined obstetric and neonatal partnership during birth. It is also an optimized program in that people who may not be able to intubate the patient indirectly can intervene in the newborn without the need for this procedure. In a study conducted in Canada, considering only the intubation procedure among NRP procedures, it was determined that the success of the first practitioner was 73%. In comparison, the success of the residents was 63% and was described as failure. The same study also stated that these rates were between 50 to 62% for the USA. 14 in the study in India. It was understood that most physicians were optimistic about the endotracheal aspiration procedure. The survey showed that pediatric surgeons in our country determined that respiratory support for the newborn is essential. Unlike India, in our country, the majority, 70%, stated that laryngeal mask application, not endotracheal tube, could be applied. The study conducted in India determined that 63.5% of the physicians started giving oxygen from the beginning and did not prefer room air. It has been stated that this rate is approximately 15% in the United Kingdom. This rate was 97% in Canada and 71.7% in the United Kingdom. It has been stated that pediatric surgeons, especially those who take the NRP course in our country, have knowledge and skills regarding laryngeal mask insertion, oxygen, and respiratory support. It is understood that residents need more awareness of this. Considering that the number of NRP course recipients for residents is limited, it was thought that an NRP course for respiratory support would be meaningful. In the study conducted in India, it was observed that 54% of the participating physicians worked in neonatal intensive care units and provided variable information about umbilical cord clamping. The cord was clamped and cut immediately in 61.9% of the cases, while the rest waited 1 minute. In our survey, pediatric surgeons were not asked about clamping the umbilical cord during birth, as pediatric surgeons' almost ability to insert an umbilical cord catheter when necessary was significant. It has been determined that there are significant differences between the training received in countries such as Canada, Oman, Poland, Spain, Nepal, and the United Kingdom, and the use of these trainings as standard. Studies show that NRP training is forgotten within 6 to 12 months if not used effectively. For this reason, more frequent rotations in neonatal care units are envisaged. Simulation training has been developed in case there are problems in achieving this due to technical and process problems. It was understood in our study that pediatric surgeons and residents constitute the minority of those who have taken the course less than 5 years ago. We thought that the course is not taken regularly because it seems to have low priority for pediatric surgeons to take it. During NRP implementations, it has been determined that 30% of the steps are skipped. There is an opinion that this situation is related to not showing teamwork activity. The study suggested that the application could be more effective if teamwork were carried out. 15. It has been reported that this aspect of the role-play process could be stronger due to the lack of teamwork training in the NRP course. 15. Although there will be little need for pediatric surgeons to apply NRP in our country, it is understood that they want to take part in teamwork by attending courses. Not taking repeat courses suggests that there will be deficiencies in practice. No questions were asked about this in our study. Conclusion: this study would fill a gap in the literature in evaluating the participation, perspective, and opinions of pediatric surgery researchers and specialists in NRP courses. The fact that the majority of studies in the literature concluded that nurses, midwives, pediatricians, and anesthesia indirectly prevents other branches from emerging to contribute intrapartum applications at IT is understood from this study that pediatric surgeons can be quickly adapted to NRP practices and take an active role.